Hereby, I open this academic ceremony in which Mr. Anniruddha Agarwal will defend his academic thesis entitled Imaging in UVEITIS, Use of Optical Coherence Tomography and Optical Coherence Tomography, Angiography in Posterior UVEITIS. May I invite you to present a summary of your study and the conclusion of your thesis in the next 15 minutes. I'd like to give you the word.
Thank you. Dear Prohector, members of the Defense Committee, dear supervisors, dear family, friends and colleagues, thank you for attending my PhD defense. In the next 15 minutes, I will present a brief introduction of my thesis, imaging of the eye in inflammatory diseases, including the non-invasive techniques used for the imaging. This is a brief outline of my presentation, which will begin with an introduction to the structures of the eye and then move on to the finer details of the blood supply to the two most important structures related to visual function, which is the retina and the choroid, and then the abnormalities including new blood vessel formation. The structure of the eye is very intriguing and is made up of fine, thin layers. The cut section here shows the tissue, which is colored in blue in the front, is called the iris, continues behind to form the ciliary body and the choroid. Now the choroid receives the maximum blood supply in the body per gram tissue compared to any other organ, and the white portion on the outside is called as the sclera. The orange thin layer on the inside is the film, like in your cameras, and this is responsible for vision. With new technology, we can capture photographs of the retina and the choroid non-invasively. A light wave belonging to a specific wavelength is used to enter the eye and capture the cross-section photographs of the retina, and this tool is called as the OCT, or Optical Coherence Tomography. OCT is an essential investigation that all retina specialists use in their clinics to manage diagnosed patients with macular degeneration, stroke in the eye, diabetes, retinopathy, and so many other diseases. OCT angiography, or OCTA, is a type of OCT that uses light waves to create detailed maps of blood vessels in the retina and in the choroid. The technology of OCT has brought a paradigm change in the management of patients with eye diseases. Indeed, OCT is an in vivo histology, which means that it helps to demonstrate cross-sections of living tissue without the need of any invasive biopsy. This cross-section shows the tissue with a typical concavity here, and this is called as the retina, and the deeper choroid below, the bright layer of the visual cells. The OCT allows detection of pathology in the structure, abnormalities of blood supply, and abnormal leakage. A single scan of the OCT shows different layers of the retina, and one can capture multiple images on the same day or serially during follow-ups and monitor the disease activity. You can document the lesion location, severity, shape, size by analyzing the OCT. OCTA further adds diagnostic value because of the maps it creates of tiny blood vessels which are obtained accurately with this tool. And one can visualize the larger blood vessels in the superficial retina and deep capillaries, small branches in the deep retinal tissue. So you can detect small changes as small as 10 microns using these images. And all of this is non-invasive. When you combine OCT and OCTA, they become powerful tools in the clinic to diagnose, measure, and quantify disease activity. In the context of inflammation of the eye, which we call as uveitis, this is extremely important because the diseases can be caused from maybe viral infections, parasitic infections, or even life-threatening autoimmune conditions. When we started our PhD thesis, the broad aim of the study was to determine whether changes in the blood supply are relevant in inflammatory eye diseases, and if yes, how do they differ from normal individuals? How do they evolve with treatment? Can we do something to preserve vision or even improve the blood supply? As you can see, the OCTA images can be converted into black and white. So whatever is dark is black and light is white. And using this, we can measure the blood supply like a mathematical equation. This can be repeated several times on hundreds of images using an imaging pipeline. One aspect in the image analysis is employing simple tools of geometry. So if you imagine a young, healthy tree, it will be full of complex, tiny branches in all directions. Whereas an unhealthy tree will appear simpler with fewer branching. And this concept is called fractal dimension, and we can extrapolate it to blood vessels of the retina. OCTA images can be analyzed to determine the fractal dimension. You can compare healthy individuals with patients with inflammation in the eye. In the era of automation, we can generate an algorithm that can follow fixed steps. For example, climbing the same ladder with the same number of steps in the exact same manner. So we can feed thousands of images in this pipeline and determine areas that have abnormal blood supply. So this particular is a patient example who worsened without treatment from baseline to 1 month. And you see the algorithm has generated the white areas which signify decreased blood supply. In our studies, we observe that OCTA is highly capable of detecting these changes objectively, and these can be used as biomarkers for recovery in clinical trials. Another broad question that we attempted to address was whether OCT and OCTA can be applied to identify the cause of eye inflammation. So can you obtain a simple photograph within a few seconds and contemplate on the cause for the disease? This slide shows diverse appearance of OCT images, different pathologies. A word of caution, in real life, clinical situations may not be so black and white always. But these case examples show the diverse pattern of involvement. So you have on one side, you have a parasitic infection called toxoplasma, and then you have a cancer called lymphoma, which is affecting the eye, and you have a viral infection affecting the retina. We observe that OCT and OCTA can complement your laboratory testing, enabling the clinician to narrow down to the diagnosis and rule out some other diseases. In one example before, we saw how a patient worsened without treatment and had reduction in blood supply. In this example, you have a different patient from baseline to 3 months, and he showed an improvement with reduction in the black areas. These images are taken at the same level. So you see, with treatment, these areas, the blood supply came back. The black areas decreased. There was a recovery of normal visual function. What we realized is that if a lesion is small, they resolve with less scarring, less permanent loss of blood supply. Large lesions, they leave behind scarring, lack of blood flow, loss of vital tissue, and cells causing functional loss. The greatest advantage of OCT and OCTA is the ability to detect changes that you will otherwise miss, and it will be impossible to visualize. It is possible to identify changes below the retinal tissue before they can be seen clinically. Now, the most important pathology that can lead to compromise in the vision is growth of new blood vessels, which can happen in patients with inflammation. These vessels are fragile, they bleed, and they can scar. The following case example, it illustrates the use of OCT and OCTA in such a scenario. This is a retinal photograph of a young Asian Indian girl who had decreased vision in both eyes. Now we are focusing on the right eye. She was diagnosed with a specific immune-mediated eye inflammation. Now, it is possible for us to detect this small yellow lesion in the center of the retina in her right eye. And OCT gives more important information related to this lesion. So we obtained cross-sectional OCT in November 2020 and again 8 months later in June 2021. If you attempt to spot the difference, there's hardly any difference that you can see between the two scans. It's likely that the disease is stable, things are in control. But if you look at the OCTA in November 2020, you see this bright spot here, which signifies abnormal new vessels under the retina. Much to our surprise, in June 2021, the OCTA through the same area shows that these blood vessels have grown extensively. Now, this is a significant finding. It impacts the vision and the further treatment for this patient. So OCTA was found to be extremely useful in detecting the underlying complications, such as new blood vessel formation in certain inflammatory eye diseases. And with that, I would like to mention that imaging using OCT and OCTA is an exciting field of research. There are countless possibilities, opportunities, and many more aspects waiting to be explored. I thank you for your patient listening and would like to give back the word to our prorector. Thank you.
Thank you very much, Mr. Agarwal, dear candidate, for your clear presentation. Well illustrated, I must confess, and I think it has enough material to start a discussion here inside. Also, you finished already in 10 minutes, so we have 5 minutes over, and we're going to use these 5 minutes extra. Yes. So don't think that you're going to save them. No, that's not the idea. The opposition will be opened by Professor Salvacool. He is involved in the Department of Medical Microbiology at our university, and I would like to give him the first opportunity to discuss with you. Professor Salvacool.
Thank you, Mr. Prorector. Dear candidate, before I want to start our discussion, I want to congratulate you and your promotion team with this beautiful thesis. Impressive not only what's in the thesis, but also what you already did in this field, because you're not a standard PhD looking at what we normally have discussion with. Nevertheless, there's always things to discuss, so I will take this moment to do that with you. And to start off with, as you told in your introduction, you described the importance and opportunities and developments in imaging technologies in relation to UVEITIS. But I'm a microbiologist, as you have heard, and there's not that much microbiology, although there were 2 pictures in it, with toxoplasmosis and viral. So I want to focus on the consequences which you describe of these imaging techniques. How will they influence the role of microbiological diagnostics, do you think?
Highly esteemed opponent, thank you very much for the question. I think this is really the final frontier that we encounter when we deal with patients of ocular inflammation related to infections. Some of the infections that we encounter in our clinics are often sight-threatening and they require immediate treatment. They're an ocular emergency. For example, if you have a viral infection, you need to start treatment today. The challenge that we face as a clinician is to obtain that precious sample and put it under the slide. And this challenge is compounded by the fact that you cannot easily enter the eye, take the sample, because 1, it is a vision-threatening procedure itself. Number 2, the yield may be very low. You may not grow organisms. And a classic example of that is ocular TB, tuberculosis. So we do rely, for sure, as a gold standard on microbiology, and we are often relying on techniques such as polymerase chain reaction. The role of OCT and OCTA comes as an optical biopsy. So you look at the section and correlate with published histology, and you can understand that certain organisms have a biological behavior. For example, certain viruses like herpes viruses, they love the retinal arteries. And so you can see them traveling from the retinal pigment epithelium all the way to the inner retina. And they appear as distinct white lines on the retina. So when you look at the OCT, you are not 100% sure that this is viral, but you can go in that particular direction, at least start treatment to prevent a vision loss. And of course, you can at ease look at microbiology, involve colleagues from microbiology and other specialties, and arrive at a diagnosis.
So in general, if I understand you correctly, we don't have to adapt our technologies because microbiology is also shifting from classical culture to all completely
Yes.
molecular diagnostics. So that speeds up also the diagnostics on the microbiological part. But if I understand you correctly, you can already say whether you are dealing with an herpes virus based on the radiographic pictures. But can you also monitor then, if you can do that, can you monitor whether treatment or putative treatment has a beneficial effect or not? So, because we see a lot of viruses also becoming resistant to therapeutics, can you see whether the field is improving by your technologies, whether the patient is improving by your technologies?
Yes, thank you.
If you follow that up.
Yes, and that's the beauty of these non-invasive techniques. You can do imaging hundreds of times, and you can quantify in the clinic the size of the lesion, the changes in morphology. You see that the lesion is now becoming a scar, it's no longer active, and we have tools to do that in the clinic, and so this is very helpful. You did mention a change from microbiological point of view. Do you need to change? There are some aspects, I think, which have really added advantages, such as backtech cultures, which are now being done, rapid cultures, which were not there maybe a few years ago or decades ago, and these are indeed helpful. We do have sampling possible with a very tiny amount of fluid, 0.3 microliters. Nowadays is sufficient to...
But still, if I may interrupt you,
Yes.
backtech takes time.
Yes.
Because you are waiting on the growth of the bacterium. So
Yes.
and sometimes you don't have that time, especially when you talk about TB, it still takes a long time. So I personally think that we should move to another way of thinking about integrating microbiology and other disciplines by integrated diagnostics, so that we can add on what really is happening. And there, artificial intelligence comes into the picture. And talking about the artificial intelligence into the picture, I saw that the front of your thesis, I understood, is also a matter of artificial intelligence, or at least a picture of that. Do you think that using artificial intelligence in combination with rapid molecular microbiology techniques will be a game changer also in inflammatory uveitis?
You're absolutely right. This is exactly hitting the nail on the head. If we are able to achieve this frontier, I think we will solve a lot of our problems. In so many diseases like TB, viral, parasitic infections, combining these two technologies is really the goal. If you look at some of the recent consensus that have been published by the American Uveitis Society and the SUN criteria, they all depend on imaging, and they use artificial intelligence as a component in the diagnostic criteria. So I think we are going in that direction. And in the next few years, I think we can visualize this happening.
Okay, thank you very much. I'm glad I don't lose my job, so I give back the word to the prorector.
Thank you very much. The opposition will now be continued by Dr. Van Paasen. He is involved in the Department of Internal Medicine and in particularly with the affiliation in clinical immunology. And I would like to give him also an opportunity to discuss with you.
Thank you very much, Mr. Prorector, and thank you very much, dear candidate. I also can congratulate you and your team with, for me, a very impressive work and also a work I learn a lot from. I see a lot of patients together with Dr. Erkens, the eye doctors, but I approach them as an immunologist, so I want to know, is it active or is it not active? And I would like to ask my first question referring to a patient I saw this morning. It was a patient of Dr. Erkens, and it's a male, 62 years of age, who's known with relapsing, remitting posterior uveitis, and he's known with underlying ANCA vasculitis, which is one of my hobbies. And Dr. Erkens, I checked the charts, says, well, the foveal thickness changed and there is macular edema, so it is active. And I was wondering, what do I have to change in treatment? But he only performed OCT. And my question to you is, knowing that vasculitis also induces granuloma formation and induces coagulation and other, well, not so very pleasant things, do you think you should add other techniques to the OCT that Dr. Erkens? I don't want to put you between you, but do you think you should add OCTA or other techniques?
Esteemed Doctor, and thank you for the question. I think your question is very relevant because it represents the connection that we as ophthalmologists and immunologists need to establish. In this context that you explained, this is a patient who has macular edema, which is by itself a sign of an active systemic disease reflecting in the eye. Cystoid macular edema is diagnosed standalone by an OCT, and so an OCT by itself would be sufficient to tell us that the patient probably needs better control, higher immunosuppression, or a local therapy in the form of, let's say, an injection in the eye. The role of OCT angiography here is limited. It comes into play if you are suspecting a complication, such as neovascularization, where you expect bleeding, scarring. In those situations, you would definitely aim for an OCT angiography. In this limited situation that you described, I think OCT, what I could possibly add is a fluorescein angiography, and maybe Dr. Erkens will agree that that will give us further evidence that there is active leakage and the patient needs further treatment.
Okay, that clarifies a lot to me, but so you don't expect any neovascularization as you showed in your patient?
So if you suspect a neovascularization, you will see it on OCT as well. Okay. There are certain features on the OCT like presence of a membrane, the structures, hyperreflectivity, and then of course you can get a OCT angiography.
Okay, thank you. I would like to take you along with the same patient because we always have to think of novel treatments, and to me treating uveitis is sort of black box medicine, which is often the case in our field. So we can give TNF blockade, we can give steroids, cells, we can actually give them everything. But there's a new kid on the block, and that's complement blockade. And the macula is also very involved with complement activity. Do you have any idea how we could prove that complement overactivity may take place in this patient? Do you have any way of thinking about novel imaging modalities?
I think the point here is the level of inflammatory cytokines that you expect in the intraocular fluid. The eye being such an immune-privileged organ that you may have specific pathways working towards inflammation. So for example, you may have an interleukin-17 mediated inflammation, or it could be a broad inflammation like an IL-6 mediated. So the final frontier to achieve this is by taking the fluid and doing proteomics, or getting the gene expression to look at the complement factor activation in the eye. May not be possible for all patients, but experience suggests very limited experience with complement inhibition as of today. It may change. We have so many agents, and typically, there are examples of published literature where proteomics has shown elevated interleukin-17, and let's say you treat with anti-interleukin-17, but the therapeutic response is not up to the mark. You still may need to give a broader agent. So there is a disconnect. It's a difficult question to answer, but I think we need to look at this more.
Yeah, that's a really great answer. Moving on, do you think that molecular imaging, for instance, with labeled annexin, which takes place in eye disease, as I know, is something to use in the future also in these kind of patients?
Absolutely. I think this involves big data analysis, exome analysis, as you said, next-gen sequencing. I would mention microbiome is catching up. Mm-hmm. And we are looking at treating patients with antibiotics in some instances. Again, there is a limited experience in clinical practice. We have a lot going on the lab side of it. I hope it translates into clinical practice soon.
But I was referring to the molecular imaging. I mean, is that something you use already or are planning to use? So labeled annexin, which has been shown also in men, that it demonstrates clotting in the eye?
I apologize. I have very limited experience with this. I'm not sure if any colleague is on it.
Okay, great. I'm not sure whether I have still...
You have 2 minutes left.
Okay, you mentioned the word, and I'm very intrigued by it. I read that that there are many patients that had COVID-related and vaccination-related eye problems, and we've been taught always in the past that the eye is immune privileged, as you said. Do you still think that concept holds true? The concept of privileged eye, like in the anterior chamber, or do you think that's really an old-fashioned concept?
I think I published actually a systematic review on COVID and implications in the eye. I do believe that it is responsible for some of the external outcomes such as conjunctivitis, atopy, and allergies. To say that COVID can cause blockage of the retinal vessels, there are cases, and to document that, I'm not sure how far we can be confident in saying yes, but it definitely acts like an immune trigger. There are several published reports of an reactivation of an immunologic disease in patients who've had COVID. So it is playing a role. How it's doing it, it's very difficult to answer.
Okay, I'm very satisfied. Thank you very much.
Thank you.
Thank you very much. The opposition now will be continued by Dr. van Veldhoven. She was also a member of your assessment committee, and she is involved in the Department of Ophthalmology at the Eye Clinic in Rotterdam. And of course, I have to thank her first that she came all the way from Rotterdam today, which is also affiliated with the River Maas, so that's not too far away. And I would like to give her the word.
Thank you, Pro-Rector. Dear candidates, it's first of all, I'd like to congratulate you and your team and all the effort that you put into establishing this work. As said, I'm from Rotterdam, from the eye hospital, and my expertise is in UVEITIS, and next to me is my personal supervisor for my PhD. It's been a long time, but it was also on OCT. Back to that, I would like to discuss with you something about chapter 4. You've put down a very elaborate review, but it dates back to 2018. So given the time, it would be that probably the last included papers will be from 2017. And since then, I think there's been a lot of progression and new insights. So my first question would be, do you think that there are new parameters, imaging parameters that are being published now that help us better to differentiate between active inflammatory CMV and active inflammatory lesions? And would you be willing to put down another review for that, or do you think that your review is still valid?
Esteemed opponent, thank you so much for the question. What you say is exactly is very right. Things have changed, I believe, from 2018 till from then till now. In terms of your question, which is active choroidal neovascularization, in 2018, a lot of clinicians were not sure when they looked at an OCT angiography and conclusively say whether it's a mature vessel or it's an immature vessel. Do you treat? Do you not treat? So this was, I think, the debate in 2018. Since then, I think the technology has evolved. We have now parameters and metrics such as fractal analysis. We do have image compensation. We depend on NFAS imaging, for instance, and we look at the progression of the disease. So we do pay attention on the branching pattern, the surrounding halo, if there is any lack of perfusion. We identify risk factors for the growth of CNV. So there has been a strong emphasis on measuring these parameters, especially in an automated manner. Things are getting more difficult, going in the direction of MATLAB softwares and based on imaging algorithms by which you can possibly arrive at a risk score and get help to decide whether you need to treat or not. So I think this is still an ongoing progress, and I think this definitely deserves to be reviewed. I think in the field of uveitis, we are lagging behind our colleagues from medical retina who have advanced in this direction in macular degeneration and diabetic retinopathy. We are yet to catch up.
Yes. And to get back on, because from the inflammatory CMV part, I agree, but do you think there are also more parameters that you should maybe look back into your own series in OCT imaging that would help you to distinguish the inflammatory choroidal inflammation?
If I have the opportunity to go back to my images, I would love to look at the morphological pattern of involvement and possibly measure, for example, the size and height of pigment epithelial detachments. I would like to measure the compartment of fluid. That would help me to identify if there is a risk factor of progression. I would also go back, maybe do fractal analysis on some of the choroidal neovascularization. Now I have a longer follow-up. So I think there are several areas that we can revisit and go back. And again, like I said, consider the literature published from the medical retina colleagues and extrapolate those to my images.
And do you think that measuring focal choroidal thickness would be, in hindsight, be visible in your data sets?
I think choroidal thickness measurement has several limitations. And while it was the only thing that we could do in the past, I think using choroidal thickness standalone has now we learned that there have been several bias that can be introduced by the measuring expert himself. It's a dynamic entity, depends on the time of the day. It's different from patient to patient. Until today, I don't think we have a real definition for pachychoroid, for example. We don't know the normal thickness. So to depend solely on choroidal thickness, I think is a challenge. There was also another parameter, which is CVI, choroidal vascularity index. I think that also has a lot of limitations. These are really quasi parameters we use to learn about the vascularity. So I think they cannot be taken standalone.
They need to have more exploring to do. Getting back on your a little bit further back on the therapy in these patients, because we see a lot of active choroiditis patients, and they have on and off activation and or not, and sometimes you miss it in the clinics. But there is a tendency towards being more aggressive in treatment, and your review touches a little bit on that, and also in the other papers. But what would be your opinion? Because there are several publications also from the group in Utrecht that if you have aggressive immunosuppressive treatment from onset, that you prevent a lot of these neovascularizations and atrophy formation in choroiditis. What's your opinion on that?
When you consider autoimmune or garden variety of choroiditis, such as white spot syndromes, let's look at the individual entities like multifocal choroiditis or punctate. I think by the nature of their pathology, they are highly likely to develop choroidal neovascularization. And in these patients, I believe that if you start treatment on the right note, which is with aggressive immunosuppression, I think the long-term results are quite good, rather than them having a slow progression and over a period of 5 to 6 years developing complications. For instance, if you have a patient of birdshot, I think these patients are going to progress unless aggressively treated. So we do have to consider specific entities. We do have patients who could be managed on single immunosuppressive agent. We do have patients who could be, like for example, JIA, if started on biological treatment, they do well in terms of the incidence of hypotony and the incidence of band-shaped keratopathy. So I think it's very important to look for the uveitis specialist to look at the demographics where he's practicing, what is the experience of patients in that area, the ethnicity, and the phenotype of the disease. And over a period of years, learn from his experience or her experience how they would best manage.
Okay. I still have time for one question.
A short question.
A short question, okay. In chapter 6, I'm staying in the multifocal area. You show in the table that actually almost all of the patients have immunosuppressive therapy, and that have still had active or CMV throughout the period. And my question is, because I looked at the methods and it was a bit unclear for me, at what time point did you choose the image to analyze? Because I would, and my next question would be then, why didn't you choose to have a longitudinal follow-up and multiple image measurements?
Thank you for the question. These patients were imaged at baseline when they were on stable corticosteroid therapy, which is less than 10 milligrams, or on stable immunosuppressive therapies at baseline. So they may not necessarily have had a controlled inflammation. Maybe the inflammation would have been controlled over a period of next few weeks. If I remember correctly, I think the follow-up for these patients was about 3 months.
According to the table, it's
No, that's a
almost
second,
2
that's
years.
a second question.
Sorry.
We have to interrupt because we have to continue. I'm sorry for that. Okay.
No, it's okay.
One question. I'm very strict in that one. So we have to continue, and we move forward to Professor Beckers. She was also a member of your assessment committee, and she's affiliated with the Department of Ophthalmology, in particular with glaucoma, and I'd like to give her the word.
Thank you, Mr. Pro-Rector. Dear candidate, firstly, I would also like to congratulate you with your tremendous amount of work that you have done, which is truly amazing, and all the work that's been done with your supervising team. So congratulations. As you already heard, I'm not an uveitis specialist, not at all, but my expertise lies within glaucoma and the field of glaucoma surgery in particular. And together with your co-supervisor, Dr. Erkens, we have already seen and treated lots of difficult uveitis patients throughout the years, in which secondary glaucoma has become a big topic. And in this slide, I would like to discuss several problems connected with secondary glaucoma with you. My first question would be on chapter 2. I was intrigued where you mention on page 26 that with fundus autofluorescence, you can characterize disease variants of, like, say, multifocal choroiditis and punctate inner choroidopathy in patients with acute vision loss or paracentral scotomas. And in this subset of patients, you have areas that you found areas that corresponded to attenuation of photoreceptor complex found in OCT and visual defects on perimetry. And this, I think, is very interesting because sometimes for us it is very difficult to distinguish which visual field loss is the result of raised IOP and glaucoma or subsequent secondary glaucoma that can be caused by the disease in itself. An example is sarcoidosis, in which it can be very, very difficult to see what is what. So my question to you would be, how can imaging, and which imaging then, help us to distinguish progressive visual field loss in uveitic patients who have also been treated with glaucoma surgery and have low IOPs? And we don't know what to do. Do you have an answer on that?
Highly esteemed opponent, thank you so much for the question. The simple answer to that would be 2 imaging techniques. One would be microperimetry, where you can, microperimetry, as you know, is a technique where you can superimpose the impulse on the retinal architecture itself, the fundus, and see which sector or which part of the retina is functioning, and gives you a very good structure-function correlation. Another test that could be done in these patients to distinguish whether it's a glaucomatous field defect or defect due to an inflammation could be ganglion cell analysis. And I think the ganglion cell analysis plays a very important role in glaucoma, maybe not so much in uveitis.
Yeah.
So,
and which one do you mean then? How do you do that, ganglion cell analysis?
Ganglion cell analysis is possible using Cirrus or other OCT devices. It is challenging to say the least, but if you get a very good ganglion cell map, you could look at focal defects and then pinpoint the area where there could be a functional loss. I think if you identify a visual field defect in a patient who has, let's say, a focal lesion, let's say multifocal choroiditis, correlating that functional loss with an OCT that shows the lesion itself will, I think, help decide if it's a glaucomatous field defect, which is probably unlikely to be very focal. Glaucoma would be probably in a certain pattern that it would occur. And of course, if you have the previous history of the patient, which sometimes we don't often have. So it is navigating through different imaging techniques, maybe combining a few of them.
Would you also see a place for OCT angiography in this? And as a combination of techniques? Because yes, it's true what you say, but then I'm still worrying about how often I should monitor these patients And can I send them away for 1 year? Should it keep them on steroids, which also can give problems, etc.? So I'm still not convinced that this is the answer for me. Have you more suggestions?
I agree with you. This is challenging. To use OCT angiography would also probably not give us the right answer, because you would look at the vascularity and you really need to probably measure it every time. It may be challenging in the clinic when you're with lots of patients. Some of these patients could be managed by looking at OCTs of the nerve, and you just rely on the thickness of the retinal nerve fiber layer rather than the field defect. So I think in these patients you could possibly follow them just on the basis of parameters such as the nerve fiber layer thickness. You have limited options, yes, and so I think measurement of IOP and the nerve fiber layer defect may be the only options that you may have.
Okay, thank you about that. And I would like to continue with the question in chapter 9. Because there you speak about OCTA and demonstrating choriocapillaris recovery with corticosteroid treatment. This intrigued me as well, because sometimes when we choose to treat patients with surgery for secondary glaucoma and uveitis, I was also looking with as always, what's the exact time that we can treat this patient and how to treat him in advance? Should we give them more steroids? Should we give them biologicals? When is it safe to treat these patients? I think 2 weeks ago I had to operate on a patient who still had kids with macular edema. So we took the risk because his pressure was 50. These are challenges for the practice. Do you have any suggestions on that? How can we monitor perhaps steroid use with OCTA or other options?
I think that is a very challenging situation when you are faced with patients with very high intraocular pressure. At times you are forced to operate. These patients typically would require aggressive immunosuppressive therapies. Often we have to give them a pulse corticosteroid dose in case you have an uncontrolled inflammation such as with macular edema. And I think OCT and OCT angiography do play a role in monitoring the inflammation in these patients and can be useful to guide your treatments. You may not achieve resolution of blood supply in the choroid in these patients despite the maximum efforts, but in those patients maybe you could limit the progression of the disease. So I think doing the OCT and OCT angio serially in these patients is a very useful thing to do in the clinic, and you must, I think, look back at these images in your free time in the clinic to then contemplate on how you would like to manage them further. It is a challenging job to do.
Is there still time for one short question?
I have to apologize.
Okay, thank you. Then
I'm
I'm
sorry.
quite satisfied with your answer. Thank you.
We have to move forward because we have 2 more opponents who are also eagerly want to discuss with you. We move further to Professor de Smet. He is involved in the Department of Ophthalmology, and particularly in relation to inflammation and retinal surgery of the Institute Micro-Invasive Ocular Surgery. I assume at CHUV
it's related to it, yeah.
Yes, in Lausanne. And I would like to give you the word. And of course, first of all, thank you that you came all the way from Lausanne to Maastricht to attend this thesis.
It's of course a pleasure to be here and to be able to participate pro rector. And dear opponent, it's first let me congratulate you on this book and also the numerous publications you've already been able to write in such a short period of time. It's you have a great career in front of you. I'll first start with chapter 4 that was already mentioned a little bit earlier, and you were asked about should there be changes to the future. I'd like to go to the past, because in your chapter you mentioned that the only treatment that was available in the past was laser. And is that still your position today? Because I can recall that even before we had OCTs, we would treat neovascular membranes in AMD, in uveitis by using heavy immunosuppression and had very good results with this. And yet you do not really mention this in this thesis or in this article. And I wonder whether your position with more experience has changed.
highly esteemed opponent. Thank you so much for the question. You rightly mentioned that laser was definitely an option in the past that we used to perform along with highly aggressive immunosuppressive therapy. So far as laser, I have very limited experience using it in eyes with uveitis. I think since we have the anti-VEGF era, even with an immunosuppressive therapy, I think anti-VEGFs have been the game changer, and they have, yes.
Yeah, I think the anti-VEGFs are a game changer because they're easy to use.
Yes.
But the problem with anti-VEGFs you have to agree with is that it stops the progress of neovascularization but does not allow regression. And yet if you go back to the old literature, you'll see that we saw regression of neovascular membranes, and this is what I miss with anti-VEGF. And so I would argue, and I do with a lot of uveitis experts, young uveitis experts, that it is a mistake to only look at anti-VEGF as being a solution.
Yes, I respect your opinion. I think you're right. We need to understand that aggressive immunosuppression is not an option. It is necessary to prevent vision loss in these eyes. And I think anti-VEGF is an adjuvant therapy. It's not really the primary modality, because you can use anti-VEGF only once the choroidal neovascularization has developed indeed. So,
okay, so then let me come to your chapter number 6, where you've in fact looked at the neovascular membrane in these lesions. And when I read chapter 6, I really get the impression that you have an all or none phenomenon. It's neovascularization, or otherwise it's inflammatory disease. And if it's neovascularization, it's anti-VEGF, and we don't need anything else. And so I think it's in fact the neovascularization comes as a result of the inflammation. And so within those lesions, is there a way to know the degree to which the primary process is inflammatory, or to which degree is it just a neovascularization? Any thoughts?
to determine if the lesion is, how much of the lesion is inflammatory and how much is neovascular, again, we have to borrow some expertise from medical retina colleagues, specifically in age-related macular degeneration, in which investigators have looked at the subretinal hyperreflective material, or SHREM, and we look at the degree or the proportion of vascularity within the hyperreflective material. This is something that we could do in eyes with uveitis, and of course I think we need to consider the role of fluorescein angiography and indocyanine green angiography, because that I think cannot be replaced by OCT angio. You do need to look at vascular leakage, macular edema, for instance, on fluorescein and ICG as well. So I think you have to use a combination of tools and certain techniques from medical retina colleagues, combine all of this to be able to address whether it's how much of it is inflammation, how much of it is vascular. But you're right, I agree with you that without ongoing inflammation, it is not possible for the patient to develop neovascularization. It is indeed, they go hand in hand.
So that would be a nice extension, I think, from this particular chapter, is to try and see, to what extent we can differentiate those two things. I'd like to spend some time on chapter 5 and maybe a little bit on methodology in a certain sense, because it's a beautiful idea to try and look at OCT angiography within the microvasculature and see whether patients with uveitis have suffered in a certain sense in a permanent way. But to start off with OCTA, what is the physical basis of OCTA? How does it work?
So the OCTA have different devices based on the manufacturer. They use different algorithms. We have experience with correlation, decorrelation, the SADA algorithm. We also have others. For example, you have the SADA is the one which is available in Zeiss.
But they're all based on essentially a Doppler effect.
Doppler effect, yes.
And so in OCTA, if we're looking at it, the Doppler effect is a delta in terms of the speed of fluid, right? So does that mean that when you say that there's no perfusion, there is absolutely no perfusion in that specific zone, or could it be due to a lesser flow?
Yes, not so. Black signal or no flow doesn't mean that there is no true flow. It could be from many reasons, like you said, slow, sluggish flow. Could be a signal loss, because of hyperreflective structures above. So looking at the signal strength is useful. It depends, of course, also on the nature of the pathology.
True, and so, but you know, if we're talking about pathology, you're talking of healed lesions, and you're comparing then your
Yes.
normal control, where you used age as being a determinant factor. Would the fact that there's a huge difference in vision also may potentially play a role in terms of your analysis, because that I didn't find in your article here?
Yes, you're right. I think we are limited in our analysis because one of the factors that we cannot account for is the visual acuity, which will not be compromised in healthy individuals and which will be in patients of uveitis. In that particular manuscript, we did perform a regression analysis, and in the results, you may find that the vision itself did not play a role in the metrics specifically related to the OCTA. But this is an ongoing issue because of the limited sample size that we have.
Limited sample size means that when you're looking at statistics, you have to be careful.
Yes.
And so I usually try to make direct correlations. And so was this subpopulation of your patients with uveitis that had recovered, some of them have good vision? And could you compare those to your controls, age-matched, that had good vision? And do you see differences there?
Unfortunately, the proportion of patients who resolved with very good vision were very few. They were less than 7 or 8, I believe. And so doing a meaningful analysis on only that subset would have been quite impossible. I think we need to increase the samples and circumvent, have more patients, a balanced group of patients who really improve and patients who did not improve that much.
And yet 7 patients is a good place to start. There's
Yes.
no point in getting 100 patients unless in your first 7 you do see something that makes a correlation. Because I would argue that if your vision's no good and you've had apoptosis and you've lost some of your central retinal cells, does perfusion need to be as high in that part of the eye? And maybe what you're seeing on your OCTA as being non-perfusion is simply a reduction in the amount of flow because there's no viable retina. Could that be an explanation?
Yes, it's like who came first, the chicken or the egg. So we don't know if the perfusion was lost before the functional damage or whether there was damage and so the body said we don't need to supply blood more. I think we need to perform longitudinal analysis in these eyes, and that's where I think serial monitoring of patients becomes so important. It is sometimes very difficult because you may not have those patients come to you at baseline when they're normal and then develop a disease.
So let me ask you a question because you've published this a while ago. I can't. Okay.
There is no further question.
Thank you very much.
This was the final question.
I'll give the word back to the prorector.
Thank you very much. I'm sorry to interrupt. So we continue our discussion with Dr. Thelen. He is affiliated with the Department of Ophthalmology and particularly in relation to retinal imaging of the Radboud University in Nijmegen. I also would like to welcome him this morning all the way from Nijmegen. I would like to give you the word.
Thank you, Prorector. I'm very happy to be here in Maastricht and just before the carnival starts. So it's very good to be here. And dear candidate, I'd like to congratulate you with your thesis. I really love to read it because I'm happy that finally there is some attention also in the uveitis world for the modern imaging techniques like OCTA or autofluorescence. I miss that. I do a lot of this technique in research and retinal research and also in glaucoma, but yet in uveitis, there is a lot of work to do. So congratulations, well done. I've prepared some questions for you, and first I have some work for the paronyms to do because I would like to ask the first question about statement number 5, and maybe one of the paronyms could read it.
Statement 5, optical coherence tomography and optical coherence tomography angiography are more sensitive than dye-based angiographies in quantifying the blood flow and detecting complications such as choroidal neovascularization.
Thank you very much. And this is a controversial hypothesis. Could you first define what you mean with retinal blood flow?
Esteemed opponent, thank you so much for the question. What you ask is very difficult to answer because to determine the exact blood flow within the retina is not possible. We do rely on the measures such as blood flow on the OCT, which could be a 2-dimensional image. We do have volumetric analysis three-dimensional image, that's a different metric. You can analyze the flow on fluorescein angiography or ICG, again, on a two-dimensional picture.
But what is the difference?
The difference is that we are all able to measure different metrics, and they may or may not have a correlation with each other. And to ascertain the true flow is extremely challenging because we cannot segregate the blood flow in the retina itself. It's an ocular blood flow. And so this becomes very challenging.
But what is the OCTA measuring and what is ICG and FA measuring?
The OCT angiography, depending on the slab, can tell you the flow in the superficial retina, the deep retina, or in the choriocapillaries.
Okay, I have to ask another way. So
Yes.
how does OCTA measure blood flow as you define as blood flow? And how does a dye technique measure?
The OCTA, for measuring the flow, we depend on metrics such as vascular density or flow density, which is calculated by considering the pixels.
These are the results of the measurements, but if you see the vessels in OCTA and you see it in fluorescein angiography or ICGA, why do you see it?
You see it because of the flow, so there is a signal and there is a decorrelation on the OCT angiography. So because of the movement of the red blood cells.
Yes,
Yes.
that's the important thing. So if OCTA you see red blood cells, and what do you see with the dye methods?
With the dye, you actually see the dye entering into the blood vessels and flowing because they're tagged to the blood vessels.
So can you, in your eyes, if on the one hand side you see the blood cells moving, we have discussed that this could be challenging in slow motion. So, and on the other hand, you see plasma or serum moving. So, could you directly compare these two methods?
Not always. I think that's a limitation. And I'll give you one clinical example where there is a disconnect between the flow on the ICG, for example, and on OCT angiography, and that is MUDS, which is multiple evanescent white dot syndrome, which on the OCT angiography will show normal flow. You will see a normal signal, there is flow, whereas if you do an ICG, you will see some dark areas. So this is a disconnect between the two imaging modalities, and this leads us to question the very pathology, the hypothesis, why is this happening? So we have instances where there is a complete disconnect.
Thank you. Okay, so we keep this as a controversial issue. Yes. Okay, I will like to move to chapter 2, and I will also focus on autofluorescence, which was already done a few minutes ago. And in chapter 2, you have table 1, where we state that autofluorescence mainly shows retinal pathology. Can you explain if retinal RPE pathology is the only thing that is seen with autofluorescence, or may autofluorescence be useful to show other pathologies as well?
Thank you for that. I think the autofluorescence, for sure, was established in our practice primarily to look at RPE pathology, including macular degeneration, choroiditis, looking at the activity of the disease. But I think autofluorescence has grown beyond that. Autofluorescence has a lot of newer wavelengths, such as near-infrared, blue peak autofluorescence, and these have been useful in conditions such as retinitis also. You can follow patients, for example, of cytomegalovirus.
Okay, thank you. So you have mentioned blue peak autofluorescence, which is very important. How can blue peak, if you take the example of figure 7, how can blue peak help to find where the pathology is happening in the retina?
So these wavelengths, they depend on the absorption from the different layers. So if you have a blue peak autofluorescence, it will have a different appearance compared to the standard autofluorescence in diseases which are more superficial, for instance. So in conditions such as, again, I come back to my example of MUDS, which is multiple evanescent, they may have contrasting appearance on blue peak and near-infrared autofluorescence. And in these situations, just doing an autofluorescence will immediately tell you that there is a disconnect.
But if you have retinal pathology, like in the PIC, in your
Yes.
figure 7, can you see anything with infrared? Because infrared is only dependent on melanin.
Can I do you go back to the page? Can I look at the figures?
Yes. Because if you look at the pathology of pig,
27.
This is happening in the outer retina. So how can blue peak autofluorescence help us in this?
So the figure 7 shows us the autofluorescence images and ICG and fluorescein. There is no infrared image here. It's only autofluorescence, ICG, and fluorescein. If you have to do an infrared image, infrared images have been shown actually to give a very good delineation of pathology themselves.
Mm-hmm.
Blue peak shows superficial pathology, but in certain instances it can also show damage which is in the outer retina.
It can be helpful, I think, if you have photoreceptor damage, then you have this slight increased autofluorescence.
Yes.
Perhaps we can move on to chapter 7, and there you compared several OCTA machines and the results of these. And perhaps you can explain why comparison of these different studies that you mentioned in table 2 is difficult. In these studies that used OCTA machines from OptiView, ZeissPlex Elite, and Zeiss Cirrus Angioplex. What is the difference, and why is it difficult to compare in UVEITIS?
Each device, each manufacturer has different algorithms that they use. Like I mentioned.
Dear Mr. Candidate, you are allowed to finish your answer, but you're also allowed to stop your answer and that you say this is enough. The option is to you. Would you like to answer the question or do you prefer to stop?
I will just summarize in one sentence.
Good, I give you the opportunity.
So all of these devices, they work on different algorithms based on the manufacturer, and so they may not exactly be measuring the same thing, and so we cannot directly compare them.
Thank you very much. I give the word back to the prorector.
Thank you very much. Dear Mr. Candidate, dear Mr. Agarwal, the time appointed for defending your thesis is finally over. The degree committee here present will now withdraw to discuss the quality, but in particular the way you have defended your thesis this afternoon. And I would like to request that you and your company here will wait the results of our deliberations and our return in this room. Thank you.
Thank you.
The PhD defense has now ended. The degree committee will debate the candidate's performance behind closed doors. This process usually takes about 10 minutes.
Long road to the south side. 7 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. On the line, I know you know that I can't read your mind. Years can't fly by now, don't waste all your time. Cause I'll go the extra mile. Long road to the south side, 7 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. On the dash, got my laces tied. Long road, I don't waste no time. Break rules because fate decides. With the team and we chase the light. I make a move, fall down, shake it off. I hate to lose, bad branch, break it off. No room for negativity, praise and love. Prepare for deep part cause we're taking off. Take the mileage, traveling so far from home. Gathering knowledge, other connections. I put the time in to get everything I ever hoped for. It's a challenge and we all in. It's a better future that we go for. And even though these nights seem long, I know that I am never miles in my rearview mirror. I know what it felt like. My goals only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and not. Long road to the south side. 10 miles in my rearview mirror. I know what it felt like. My goals only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and not. Years can't fly by now, don't waste all your time. 'Cause I'll go the extra mile.
Dear, still to call Mr. Candidate, dear Mr. Agarwal, the degree committee here present has assessed the quality of your thesis and in particular the way you have defended your thesis this afternoon. In view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you officially the degree of doctor. Professor Webers is authorized to confer upon you this academic distinction in accordance with Dutch university customs. And therefore I invite your supervisor now to take the floor.
Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent and responsible?
Yes, I promise.
By the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Anniruddha Agarwal, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, I now present you with the degree certificate signed by the rector, the secretary, and the other members of the committee and affixed with the official seal of the university.
You can come forward. The laudatie will be given by Professor Berendschot, and afterwards he will turn the word to me.
Okay, thank you, Prorector. Dr. Agarwal, dear Anniruddha, also on behalf of Dr. Erkens and Professor Webers, I'm very pleased to congratulate you with your PhD seals and say some words. So it was a real pleasure to guide you the last 3 years, which went by quickly and smoothly. So let me recall somewhat for the audience here and online. September 1st, 2020, in the midst of the COVID lockdown, you reached out to Professor Webers to show interest in pursuing a PhD through Maastricht University. At that time, you just had joined a large tertiary care hospital in India as a faculty member in vitreoretina and uveitis. And since I'm a kind of liaison officer with respect to our research lines in India, which are many, your request was forwarded to me, happily. Since your primary area of focus was retinal imaging, as we have seen, and since you had already published manuscript on OCT and OCTA in vitreoretinal conditions in uveitis, we quickly agreed, I think, that uveitis imaging, well, the title is it, here it is, would serve as a research project. So already September 18, very quickly, you made me a very detailed PhD research plan with brief methods and proposals for 4 to 5 manuscripts. Well, due to COVID on our side, it took some time to check your diplomas at Maastricht University and to evaluate your proposal. Well, I at least was working from home and many for us, so it wasn't that easy. But early December, we had our first Zoom meeting. We met by Zoom to discuss your research plan and in detail and face-to-face. And also from this point on, Dr. Erkens, our uveitis expert, who is also great interest in optics, joined as co-guide. We decided to have monthly Zoom meetings in January 21 onwards and agreed that we should start analyzing data and writing papers one by one. And so we had the last 2 years, always very fruitful and to the point, and in between there was a short visit to Maastricht. Well, hope you like that. Well, with some problems with the Dutch railway system, I'll hope tomorrow we will have not similar problems as then, but I hope you liked it. Well, despite moving to the Eye Institute at Cleveland Clinic, Abu Dhabi, where you now are, with all the hurdles and difficulties that come with it, your progress was impressive, I must say. Already March 21, we had our first paper submitted to ocular immunology and inflammation. That's the chapter 5 in your thesis. And so it went on and resulted in a thesis completed in about 2 years' time that you defended very, very successfully, I must say, today. Well, to me and Professor Webers and Dr. Erbkes, this came to no surprise, since you combine your clinical worth with research, well, seemingly effortless, and your CV is impressive, very impressive. Many PhD students show a single page with published papers in peer-reviewed journals. Yours have 25 pages with an impressive number of 248 that some even never reach in their total career, I must say. And you're only 37 years of age, so that's impressive. And on top of that, 39 book chapters already. Apart from this writing, you lead an international consortium on surgical management of vitreal retinal diseases with colleagues from Italy and the USA. And already in 2014, so this was recognized very early, you were awarded the gold medal in the field of medicine by the Honorable Prime Minister of India, I've been told. So this PhD is more than deserved, I would say. We're very glad, the three of us, to be part of this trajectory. From a personal point of view, I admire your modesty and friendliness. Despite being very busy with patient care and family, you're always optimistic and look positively to the future, and a bright future is ahead of you. Dear Anniruddha, I will keep it short. Keep up the good work, I must say. Let's stay in touch to collaborate and advance our understanding of uveitis and its complications. I've said, and I give the word back to the Pro-Rector.
Thank you.
Dear Dr. Agarwal, how does it feel?
Thank you so much. It feels very nice.
Thank you very much. I also would like to congratulate you on behalf of Maastricht University, of our Board of Deans. We were very impressed by your work. I received your thesis about 2 weeks ago, and I took some time also to in preparation of this defense, to read your thesis a little bit. I was, of course, like already mentioned by Dr. Berenschot, that I thought at the end it was the list of references, but it was not a list of references, it was your list of publications of 247. So I thought, what is this guy doing here? He should have been this already long time ago, so basically it's a compliment. And I also would like to congratulate the promotion team, which we heard now has guided you over the last years to get to this point. I also would like to congratulate your family, who is behind that sun care, this camera. I suppose they are back now in Dubai or
yes,
in Abu Dhabi.
In Abu Dhabi.
Yes. I would like also to thank the members of the Corona here who came over here to ask you some questions. And sometimes I refer they have 8 or 9 minutes, but it takes more time to get to these 8 or 9 minutes in travel time and collection, etc. There's one other thing I did, and then I'm closing here, I'm not talking too much. I read your acknowledgements, and I was struck by one word in your acknowledgements, and that's the word challenging. And then this afternoon, I was collecting here how often you are using in your 45-minute presentation the word challenging. Do you know how often you use that? I can tell you, 32 times. And in my world, challenging is problematic, because you avoid in the Netherlands the word problem. From problems we make challenges. So do we have 32 problems, which we haven't discussed? Anyway, saying this, we're going to close this officially. I use my hammer, which I have over here, and I'm closing officially this meeting. And how are we going to proceed? I would like to ask the members who are in the aula, I give them already the opportunity to go to the rafter and start with the first coffee, tea, juice, and maybe some pie, I have no idea. But anything, we will go here in the Corona and make a picture on the stairs of the university and then follow you also in the rafter. Thank you very much.
Thank
you.
Please come forward. Marilyn, bring the Recording stopped.